And if you would just ask everybody to speak as close to the microphone as possible. Debbie, do you want affiliation or just name? Just name is fine. I'll know the affiliation.
Okay, it's 4 o'clock. Welcome everybody. Today is a work session between the hospital board and the Petersburg Borough Assembly. Bill Hofstadter, the CEO, and the Medical Center will be facilitating the meeting. And this is just a work session between the two bodies, the Assembly and the hospital board. So there's not going to be any public input. That's the way it was designed anyway. So maybe if we could start on one side and just go around and speak. Again, we're taking a roll, but people signing in, so we don't really have to roll.
It's completely up to you, yes.
Maybe I think it would be good if we just start and introduce ourselves if there's anybody in the audience that doesn't provide one another. So I guess I could start on this side. I'm Mark Jensen. I'm the Petersburg Borough Mayor. Bob William, Assembly Member.
Marlene Cushing, PMC Board.
Sheriff Cook, PMC Chair.
Taylor Norheim, Assembly Member.
Jim Roberts, PMC Board Member.
George Doyle, PMC Board Member.
Chelsea Tremblay, Assembly Member.
Joe Stratman, PMC Board Member.
Phil Hofstadter, PMC CEO.
Brandy Merle, Assembly Member.
Jeff Mucci, Assembly Member.
And Cindy Longadakis, PMC Board.
Okay, thank you. Looks like everybody has it figured out. We need to talk close to the mics. This is being recorded, so we'll all be clear. So, with that being said, I'll turn the work session over to Mr. Hofstadter. Thank you, Phil.
Thank you. Thank you, Mr. Mayor. So I'm going to start off with the agenda. Does everyone have a copy of the agenda in front of them? This is a joint work session between the Petersburg Borough and the Petersburg Medical Center Board. So the first thing I thought we'd do is just review the strategic plan, which we reviewed and completed last year. I have a copy of one of the face sheets that just has the 5 priorities. If I could just hand a copy this way, and then I'll go this way as well. And what I'll do is we'll go over some of the 5 priorities. I don't want to spend a lot of time unless there's comments or questions. Certainly, board members or assembly can provide input. I'll provide a few high-level updates on each priority. I also have a copy of the full strategic plan here. I could leave it here with you. It's also on our website if you want to go into greater detail on those conversations from last year. And so, without further ado, I'll go ahead and talk about a few items. We also have some guests here. I'd like to introduce Dan Jardine. He's our project manager with NAC Architecture, and he's going to provide an update on the new facility planning, designing, and building for master planning. And actually, I'm going to save that one for last, even though it's number 1 on the list. I'll provide some input on each of the different priorities. Does anyone have any adjustments or comments on the agenda at all? Anything else pressing that we want to discuss that's not on the agenda? All right. So if you take a look at in front of you, the first 5 priorities, just to review, last year we spent a good portion of time with the board, and we went over some of the previous strategic plan and some of the priorities, and we set the priorities for Petersburg Medical Center for the next 5 years. And the 5 goals we chose, 1 obviously is new facility planning, designing, building. 2 is integrating care through a patient-centered medical home approach. 3 is recruitment, retention, growth of staff. 4 is community outreach, education, and communication. And 5 is to improve our financial strength. So when I'm doing things, or when we're operating, when we have board meetings, when we set goals within the organization, we have these 5 items, 5 goals in mind when we're having projects in place. So the first thing with improved financial strength, I'm going to work backwards since we land on new facility last. We've spent a lot of time in the last year digging into our financials, really spending a lot of time on workflow and efficiencies. We hired a new auditor. We have a financial consultant that's worked with us, really digging into some of the financials and improving those aspects. I feel like from an overall standpoint, and if board members want to comment on this, I feel like we're doing really well financially. We're finally able to work through some of the some issues in some level of detail we haven't been able to get to before. So I'm feeling pretty good in that area. We've also had a pretty strong showing of grants. So we have about almost $1 million in grants in the last year and a half, and we also are increasing that aspect. And so that's a strong amount, and they vary from the Rasmussen Foundation grant recently. We had the Denali Commission grant. We have a state grant for programmatic improvements, and we also have a HRSA grant that's out. We haven't received word on, but we are working towards that. And those are all with the idea and the goal to improve financial strength. We focused on community outreach, education, and communication. We had 4 community cafes in the last year, and those are all designed with the intent to provide input, education opportunities from the community, and to provide a forum and feedback from the community to help us set some goals, and also provide education on some of the service lines we have. We've developed a newsletter with our PR. We have KFSK Live. We do every month. Today we did KFSK Live with our project manager, and the idea and the intent behind that is to really provide input to the community and educate the community on some of the services we're providing. Recruitment retention, that's an ongoing effort. We have done a great job with PMC in the past. We have a great nursing program. We have outstanding staff. We have probably a 90% higher rate where they live locally, and a large portion of the workforce comes from Petersburg, which is pretty outstanding. Integrated care is really an approach where we're providing services in our primary care. So when you come into a primary care center, are we having appropriate services such as mental health? Mental health is a big area of focus in primary care. We've added service lines in our primary care with mental health. We have a grant for medication-assisted treatment. We have added chiropractor services. We've increased our therapy services. We've taken a lot of the visiting independent specialists, and we moved that process into the clinic, so there's a lot more continuity of care when specialists come on site. And that's a big change, and that's been pretty instrumental in improving some of the continuity when you have specialty services, and adding specialty services into our clinic, where we did affiliations with both with Bartlett, and we're working on an affiliation agreement with Ketchikan Peace Health. And so those continue to move forward. And then finally, our new facility. So before I have Dan talk about the master planning and some of the things that he's been can update us on, does anyone have any comments or opportunity to speak on any of those priorities or goals?
I just have one question. I missed the community cafes. I was out of town for most of them. Did you get much public interest from those, or did they generate any discussion from the public?
Yeah, the last one we did definitely was was a higher turnout. We had almost 100 community members turn out for the event total, and it was on aging in place. It was definitely a topic of interest in Petersburg. So we had the AARP representative come to Petersburg to provide input and information. I thought it was well received, and I think that there was a lot of feedback from the community. And the idea is to take that feedback and actually do something with it. So we're trying to take the concepts and the ideas from those meetings and operationalize them in some facet.
Good, thank you.
Yep.
I just have one comment. When we're calling a new facility, we're not defining that as 100% new structure. We're saying that our facility needs to be renewed and made workable for several decades into the future.
Yeah, it's hard to come up with a term on that one. Aging facility, new facility, renovation, something. Yeah, there you go. Improvements. Yeah, improvements, yep.
You mentioned during the integrated care portion of it that you're working with Peace Health.
Correct.
And what are they helping provide?
So right now, one of the gaps we have is providing procedures, so like colonoscopies, endoscopies. Peace Health has a clinician come in for OBGYN clinic, and in the past, the way it's worked is some of those independent physicians come in. I don't even know who they are. They say, I'm going to come into Petersburg, and we used to work out of the independent clinic area, but they had no affiliation with PMC, and a lot of folks didn't know that. And we do have some optometrists that come in that are not affiliated with PMC. They just provide the service, and that's fine. We're trying to retain that. But ideally, specialty services should be a continuum of care with primary care. It's a lot harder because you have to credential all the providers, which is a pretty lengthy process, and you have to have an agreement in place. And so really there's two ways to do an agreement. One is to do an MOA where you're just agreeing to share information. They still come on site. They're allowed to, work within our facility, work with our staff. But then they document and they bill through their own system. And then that's no cost to PMC. The other agreement could be where you purchase services. You say, I'm going to pay for this specialist to come in to Petersburg, and we're going to purchase your day, but we're going to document and bill on our system, and then we're just sort of renting that specialist. And so those are two different agreements.
Great.
And telepsych or psychiatry is the one that we added with Bartlett, and we're working with Ketchikan on. Right now, we're just working with surgical services, which would be endoscopy, colonoscopy. Yeah. It's good music. Any other comments or anything? All right, Dan, do you want to get your show on the road? And do we want Dan to talk into the mic?
He has one of his own.
Okay.
Thank you.
All right.
And this is working?
Yes.
Well, thank you. We actually had a very good meeting today up at the hospital with staff. But I want to put all this in perspective. What I brought up with me is a presentation that I gave previously, but I've updated the content a bit to where we are right now in the process. So I'm going to run through this, and then the bulk of the meeting will be talking about some of the initial planning we've been doing and that we've talked at length about at the hospital today. And this is my Cracker Jack team that's behind me. I don't do all this on my own. So, but as Phil was kind of referring to, the bottom line here is we're trying to determine how Petersburg Medical Center can be a viable entity and provide the best possible health care for this community well into the future. That's the grounding principle we're looking at in all of this.
There are some very specific master plan tasks that UNC Architecture has been contracted to deliver. Structural analysis, renovation study, debt capacity analysis, market service line analysis, numeric space program where they come up with the actual size of the various departments in the overall hospital. Conceptual block diagrams placed on available sites to see how the various departments would relate to each other. We finally completed cost estimates so we can understand what the associated budgets are with these various options we've been looking at. We're not doing this in a vacuum. There's quite a bit of work that's already been done up here by the hospital. This is a list of a few things that we've been looking into and delving into for background on past hospital performance, but also community input and previous studies that have been done of the existing hospital. So completed to date, we've done the seismic analysis, found a few areas of concern in the existing hospital building that would temper enthusiasm if we're continuing to use that building. We completed the inundation study, looking at what the potential risk is from a tsunami event or rising sea levels, just to kind of think, well, is there any higher risk of building down closer to the waterfront as opposed to further up the hill? The conclusion there was that there is no significant difference in risk in either location. We completed the market assessment, internal assessment, financial debt analysis, and so on. This was from our consultant Navigant. We spent quite a bit of time looking into the records that have been pulled together by the hospital, looking at the market in this area, and then also national trends and so on. Looking at the service records to kind of get an idea of where the area of service is most in need. And we took all that information and rolled it in to figure out, well, how many hospital beds do we need, how many examiners do we need, and put together the numeric space program. And this is where we sized each of the departments based on current and projected need. And when we use these sizes, and you really can't see this, but there's lots of numbers there, to drive a study of how we might put these departments together. This is an example of a similar process we did for Cascade Hospital in Leavenworth, Washington. And at this point, I kind of want to emphasize we're not designing a hospital at this point. We're looking at spatial arrangements, departmental proximities, sizes, and how all these things might fit together. You notice there's not a lot of detail here. It's basically saying what works best if we put this department here next to this one, and how does that work with the site? So, jumping right into it, those are our preliminary schemes that we've been doing. They're not quite as polished, but we looked at two basic locations. We looked at building a replacement hospital down at the existing hospital site in town, and we looked at several different ways we could build a new facility at a site uphill. It's undeveloped right now, but it's kind of across the street from the fire department. There were several green sites offered up for consideration. We picked this one to kind of focus on because there are utilities developed in place along the main road there. And utility development is a pretty heavy cost burden, so from that perspective, it was kind of a good one to look at. And we looked at several different options on that one site just to kind of compare the differences between the options rather than between the different sites. So the first one we're going to look at is down in near the existing hospital. And I'm going to quickly roll through 3 slides here because this is a 3-story scheme. The site rolls from the... do I have a pointer here?
There's one right on the desk, I think, a pointer.
Ah, there we go.
can I just, do you want me to chime in about the?
Sure.
So a couple of things with the master plan, because before even talking about renovation, new facility, aging facility, when I first came here and I met with many community members, one of the things that we needed to decide on, based on the interaction and some of the reports that were done previously, is location. Where do you build? There's a lot of strong opinion on whether you build down low, existing site, or can you get a greenfield site someplace else that makes more sense. And so what I've asked Dan to do is, because the in-place location there's in a lot of ways makes a lot of sense to stay in place, either to renovate, build new, etc. I asked him to really look at that space critically, and with the understanding that there's a couple of scenarios that in that diagram shows. One is an assumption that we have that street is vacated, which by the ER, and then there's that lot, the parking lot. But then there's also, it's the assumption, because of the space, the tightness of space. Dan, do you want to just mention that this is an assumption that would also be part where the museum also sits, right, and some of the other lots too. So there's a lot of assumptions with this diagram. I just want to preface that.
Yes, and it's important to note also that the existing hospital basically sits on this one block right here. And because of the general increase in size of the program due to greater patient room and exam room sizes that are consistent with current thinking and current code, addressing a number of space shortages that the hospital is currently facing, and generally trying to increase the efficacy of the healthcare delivery. So we're kind of growing in size, and the site, the low point is here, the high point is here. So we're taking advantage of that topography to do a 3-story scheme. And this lowest floor down here, so this is made up of sort of the central supply, maintenance, mechanical spaces. There will be a loading dock down here on this end, and there would be a corridor connection over to this side of the site here. And the next level is the bulk of the hospital. So this right here is the clinic space built on top of the central supply and the maintenance area. There would be a central entry point here on the lot. And then on this side are a lot of the patient support services. So we have the physical therapy down here, we have imaging, we have the laboratory, we have the surgery, we have the central sterile portion. Right off the entry, we have the business office and administrative areas, IT as well, and then the dietary, with potentially a cafe. So moving up to the top floor, you know what I'm going to do? Let's just kind of walk up here. It's a lot easier. So the top floor is where the long-term care would be, the acute care, and also the emergency department. The idea is that the nurse station would be centrally located, so the nurses can monitor not only the long-term care at night, but the acute care, and also keep an eye on what's going on down at the emergency department. That's a relationship that the hospital currently has, and I think it's an important one that we want to maintain. Up at the high point here, this is where the ambulance would come into the emergency department. We have an internal courtyard for use of the long-term care patients for gardening and so on. But this would also be elevated so there'd be good views out over the Narrows to the mountains and so on off the day room there. So a big challenge of doing this project, of course, is that we have an operating hospital on this site. And how do you build a new hospital where there's an existing one? And what you have to do is phase it. So right off the bat, what we'd have to do is purchase all of the property on this block, vacate the street, and the dash line here is kind of a demarcation between phase 1 and phase 2. We have to build a functioning hospital before we can shut down the existing one, which is the reason we need to grab this much space and pretty much build the functioning hospital on this side of the lot. If you go back down, floor below, we have all the integral services to support the hospital on this lot in phase 1. So once we get phase 1 done, then we can start going back to the other side and tearing down the existing hospital to build a new clinic and new support services on the other lot. And one thing we're going to do is maintain the existing 2-story clinic while we're doing that. We're launching down the existing hospital around it. And once this new clinic is built, then the existing clinic can be taken down, the rest of the site developed with parking, landscaping, activity spaces, and whatever else that makes sense to the community and the hospital. So, we had a rousing discussion about this with the staff at the hospital. There was a great deal of concern about the patient areas, long-term care and the acute care being on a different floor than the patient services, like the surgery, like laboratory, imaging, and so on. Because a lot of the inpatients access those services, and having to go up and down an elevator is an obstacle for that. Also, the long distance from this central supply area through an underground corridor, then up through a couple of elevators to get and distribute all that material out through the rest of the hospital is a concern. So I was pretty impressed with the discussion at the hospital. Staff were going, I want my office here. I want to be close to this, so it's more convenient to me. And it's really all about what was best for the patients. Thinking about how patients are going to navigate through this space, and how can I most efficiently do my work during the day if these departments are closer together, or if this particular item is over here rather than there. It's all about delivering the best health care. And that was really driving a lot of the discussion. A lot of concerns about the solution, so we moved into looking at the other site. Again, this is the site up by the hospital, up by the fire department. We went through 7 schemes, some of them 1-story, some of them 2-story. When you do a 1-story scheme, you avoid having to go up and down stairs or up and down elevators. You avoid the cost of elevators, but you tend to get spread out a little bit more. We can compress all this down, but as an architect, thinking about the experience in space, we tend to gravitate towards long, narrow lanes because you get more daylight coming into the interior spaces, which makes for a more beneficial environment and experience of the space. So this is a one-story scheme, and you'll see various organizations of these spaces, but just quickly, clinic, physical therapy right off the main entry as you come in. In this one we have the imaging, laboratory, surgery, and central sterile arranged along, so if you're coming in to get a lab test or you get an x-ray, that's convenient to you. We have the emergency department over here with a separate driveway for the ambulances. Acute care, long-term care, central nurse station, and being able to monitor the emergency department. And then sort of the support spaces off here, mechanical spaces, central supply, dietary, and the business office. That's kind of the lay of the land, what we're looking at in terms of laying the spaces out. I'm going to kind of flip through these pretty quickly and go to the end, because Scheme 7 was the one that we all kind of came down with as the best option.
Can you, and especially for people who are not here, describe the area and what is around this proposed facility? What other structures are there now?
So Main Road is here at the bottom that goes from downtown up to the airport. There's a store here on this side.
Old radio station.
Old radio station.
Daycare center now.
The rest of these properties are currently undeveloped. So it's vacant land owned entirely by the borough. So, and it's fairly flat too.
Very wet.
Yeah, there's a residential area to the west here, and the way the land is platted, there's the potential for a street to come through here. But in terms of the parcel we need to accommodate the program, it's a fairly square lot and fairly large, but
It's we looked on the map. It's right where the bend is on Hogan, and it's literally about 580 yards north. I mean, just uphill from the hospital. Yeah.
So we looked at a number of schemes. Scheme 2 was a 2-story scheme with the physical therapy and a clinic on the upper floor. Scheme 3 was another single-story scheme. We call it the squash cat scheme. There's lines that go out, from the central core, again trying to capture that daylight and bring the central connections to the middle of the plan. Scheme 4 is another single-story scheme, a little bit more drawn in and centralized in this core area here, and just have the wings going out for the long-term care and the clinic and the acute care. I'm going backwards, sorry. Scheme 5 is another 2-story scheme, trying to bring the plan back into a more narrow arrangement, but again, it's a 2-story scheme with the clinic and physical therapy on the second floor. Scheme 6 was another more compact plan, but again, a 2-floor plan with the clinic and the physical therapy up on top. The general consensus, again, was that it's much better to have a single-story plan than a 2-story plan. The clinic and physical therapy are two of the most high-risk services at the hospital, so there was a lot of interest in having that down on the ground floor. So, Scheme 7. We talked about this at length, and we have a number of variations on this that I'll be exploring when I go back. But what people liked about this was the fact that, again, the old long-term care and the acute care are fairly close to the emergency department, closer than the other schemes, because at night there's some 2 nurse staff monitoring the inpatients, and they want to be fairly close to the emergency department when someone arrives there. Liked having the clinic and the business areas in a separate sort of part of the plan, because for construction reasons, if you can build a business occupancy, which the clinic and the administrative spaces are, at a more cost-effective construction method than a hospital. We just put up a rated separation between the two, and we have that flexibility to save some money on construction costs. We looked at it in depth. They wanted to flip the dietary and the surgery back and forth because they want the dietary closer to the patient areas because it makes the transport of meals much easier, and also the patients enjoy the smells of good food cooking. We're talking about if the dietary is here, we can develop a cafe, and then rather than access the emergency department from this side, access from this side, so we can have an outdoor seating area. We also said that it would be great if we had a separate entry through the cafeteria and dietary into the patient wings for visitors to come in and visit with family. So this ended up being the most sensible scheme in terms of the hospital's analysis, with some various tweaks to it that we'll work on. And just to kind of continue on, next thing we need to do is when we do these tweaks and come down to a couple of different options to look at more seriously, we'll have our cost estimators price both of those on a square foot budget basis based on assumptions about construction type. Our estimator was up here in town a few weeks ago interviewing people at the Borough, interviewing local contractors to kind of get the lay of the land, understand what construction costs up here in this area. And then when we get those comparative cost estimates done, we'll pull all that together in the report. And the schedule is, right now we're in December, we're working on these site diagrams, and we'll do starting the estimates in December and finishing up the final MP master plan in January. So,
Yeah, I have a question. So if the choice was made to move up by towards the airport, is it going to be figured out what would happen with the old facility? And if it was demolished, what it would cost? I mean, part of the overall project, I would assume it would be.
that is one of the factors of building on a greenfield site away from the existing one, is what do you do with that existing building? The fact that there's seismic issues there kind of tempers, adapting it for reuse. So yes, in the cost estimating, we would include a budget allowance for demolishing that building. And then we have to kind of come to some conclusion as to what should happen there other than just demolition. It becomes park space, it becomes a replacement museum. Yet to be determined.
Be interesting to see.
Were there any other locations that were considered? Because you have picked the one area that's probably, other than downtown, the most traffic congested area in town.
Yes, there were, I think, 3 other greenfield sites that were put up for consideration. 2, I could probably bring it up, but there's one out by the ball fields, north of the ball fields, and there's another one that is closer to town on the other side of the development, closer to the airport. I think there's a little park there with bicycle trails and things. Yeah. In that area, I think there were 2 sites indicated there. And there was another site indicated across the street from this site. That was kind of in a depressed area.
I think.
Yeah, down below the fire station. This site is fairly flat relative to the road, so.
And another consideration with the first schematic that you gave in the existing location is that if you built across the street, we would have to have an interim plan for what we did with the museum, because that site is currently occupied by the museum, which is a borough facility, but we would either have to suspend operations or find a new location.
Temporary home. Okay, so we have some work to do. We're going to go back and pick up some of this input we got from the hospital and fine tune this, and are planning to
present again in January, I believe.
Jake, are we going to have an opportunity for community, feedback? Community cafe? Yeah. Yeah, so the next step is really in January to have Dan come back and do a equivalent of a community cafe to get feedback, present this on a more final format, and get feedback from the community. So this is a little bit hot off the presses, just FYI. I mean, I was a big fan of really staying in place and renovating.
Welcome to the GCI conference.
And I did have some concerns on the 3-story structure and the way that we couldn't really use the space. And I know Dan and I have talked about a bit. I said I just need you to squeeze in the space and come up with what it comes up with. And so anyway, it's it was a little bit of an eye-opener when we saw that today. We would have concerns on patient access, and the three stories is not really a good concept in my opinion. So anyway, just want to follow up with that, because I was a big, strong proponent of just keeping it down low, but I had some second thoughts here with this presentation.
We'd be looking at the cost differences between multi-levels and the single levels as far as heating and all those kinds of things.
Yeah, ROB, the
maintenance
of our cost estimating is used to doing these master plan study estimates, and a pretty good feel for.
Microphone, please. Sorry. Microphone. Sorry.
Yes, they'll be looking at all these components in comparison between multi-story and single-story. We also have mechanical engineer and electrical engineer and structural engineer all on board to contribute input in terms of sustainable solutions and various construction types.
So will the final master plan in January have cost estimates for both facilities, or both locations?
Yes.
Will that cost estimate also include what the prep cost of that site up there? I don't know what the Muscate is.
Absolutely, the Muscate is notorious. So you know what it costs to build a...
Obviously, you're going to have to compare those two costs, I think.
And I don't want to get too far down the road of proposing other things, but is there a possibility of swapping land with the state or requesting land from the state to put the facility in a different location? I really am opposed to the location that you've chose. I think that will cause problems. But I think being closer to the airport would be an opportunity for the hospital, and there's quite a bit of land up there if some of that was available to us.
Yeah, again, the original parameters of the contract for the master plan study identified these certain areas. So we're kind of working with those.
Okay.
There's always the possibility if another option opened up, to entertain that. I was saying I'm not aware of there being another available site downtown someplace.
Yeah, I don't think so.
Without knocking something else down.
Does any of that, do you know if any of that state land has the same utility access that this current location?
The other locations do not. We've worked with the Borough to identify what the existing infrastructure is available for other sites. The distance to go out and connect to existing utilities is significantly longer.
So one of the concerns by Cindy was the traffic. If we ended up going up by the fire station, could you access the hospital from both roads? So you'd have, instead of it all the traffic being on Hagen Drive, you could access it through the road over?
Yes, we could do that. I want to look at the impact on the adjacent residential areas if we directed traffic to the backside. If there's another way to get to the backside from
more developed area, that might be a possibility. Might be able to separate staff parking from patient parking on one side and the other. We did spend a lot of time analyzing detailed parking and circulation on the site. We're mostly focused on really getting a good understanding of the best adjacencies between departments.
Any other questions for Dan?
I guess one question for you is, how do you, your current thinking about getting community involvement in this? What is your thinking about the approach?
I think that's a good topic where we can maybe talk about that, for January. I want to make sure, my main concern is making sure the community is aware and they have the opportunity to provide the feedback. I agree. I think, location is just, we can't do anything without figuring this piece out. So the structural piece also, we haven't talked about renovation, but that really limits renovation opportunities as well, right, Dan?
Yes.
Yeah. So we, again, we have to figure out something. It's an aging facility. So I think that having the opportunity for community to provide feedback is really, really important. Yeah. Is that what you're mentioning, or do you have any?
Yeah, it has to be public vetted, I think.
Yeah.
In a longer process.
Yeah.
That gets very technical really quick.
Yep. Yeah. Not only that, infrastructure, water, electrical, power. All that there's a lot of components, moving pieces. Yep.
I do have a question. So, from what I understand, we've had multiple projects on the current hospital, and it's kind of all been scabbed together, right? So is this new facility going to be made so that in 30, 40 years we don't have to mow it down and start over? I'm hoping that it's going to be
We build a 100-year facility.
designed so that you can remodel and renovate without scabbing things together like it's been, like the current problem?
Yep.
Yes, absolutely. When you start from scratch, you have the opportunity to build in flexibility for future growth, and ability to make the best efficient arrangements and relationships between departments, and you have the ability to build something that's appropriate for the site conditions and the community. 30 years down the road, who knows what medicine's going to be like. Building that flexibility, we can try to avoid having to do remodels in the future. I'd also say that in terms of infrastructure, sustainable solutions are much more available now. And as energy technology advances, we're not going to be dealing with boilers and things like that. It's going to be very technical, be able to take advantage of gray water systems and other options to simplify the operation of the hospital.
So just a couple comments. Brandy, you were talking about the longevity of the building, and I had looked over the history of the hospital since it started in 1917, and the reality is that every 20 to 30 years we've done either major construction to add or replace to the hospital facility. So this is not something extraordinary, and certainly we'd like to make it last as long as we could, but it is what it is, and the technology does change. The other thing that I would encourage, Phil and I have jokingly talked about including the museum in a new building if we were going to do it, because we feel like I work for the museum, and we feel like we've run out of space, and we go through various granting options, and somebody looks at the facility and says you need to expand here and expand there. There have been several times in town where we could have co-located facilities and we didn't take advantage of that opportunity, and I would encourage folks to think about the ability to do that, even if it was borough offices, if we needed more space to include several things in that building and kind of maximize our dollar.
Actually, so two things on the public input process. I'm curious about details from the staff about their thoughts on the different plans. And so if there's a way maybe as this gets rolled out to the larger public, being able to present like, hey, we asked all the hospital employees, here are their thoughts, something like that might be a nice component, because it's nice for us on the outside to have opinions about it, but if 90% of the hospital staff feels a certain way, I'd like to know that as part of the broader discussion without putting them in compromising situations. Is that?
So the last slide you saw was what a lot, with the majority of the, was it slide 7, that last one, was the input from the managers, yeah.
Okay, yeah, I think that might be a nice way of presenting it to the public.
Overwhelmingly, yeah.
Okay,
overwhelmingly, yeah.
And then
I'm going to speak to the staff that are here, though. Was that, Mike, was that true?
I think it was a majority. This is a minor modification.
Yeah, they tore me apart.
There's some shuffling, but that was the majority.
I got a lot of heat on that one. Yep.
And then at the Municipal League Conference, I was able to go to the Early Childhood and Learning and Education seminar, and they mentioned childcare facilities in places as a way of helping with employee work-life balance, but also with cost sharing and overall experience. Is that something that's been part of this discussion?
We included that one, right?
It was discussed, and especially in proximity to the long-term care, the cross-generational relationship building. I don't believe we included it in the merit program at this point. So if we were going to add that, then we would have to drop that in and include it in the overall scope.
One other consideration that Sandy and I have been talking about is in a new facility and even in a remodel, there's a need for, and we can talk about that some more, Sandy can, there's a need for some space for EMTs once they deliver a patient, what have you. But they need a place to do their paperwork and to do, to clean up and do some other things. And I think that needs to be also, I don't know if you thought about it, Phil, but I think that really needs to be included in something like that. And would you add to that, Sandy, or you?
Yeah, just a little closet or something, because right now we work at the end of the counter, so we're in the way of the staff.
Yeah, I've designed a number of emergency departments, and that's always a piece of the program. Right inside the main entries, you have a space for the EMTs to sit down and complete their group of work, and usually a security office nearby as well. Because of the size of the emergency department here and the low volume of use, that's probably not going to be a room, but it will be a space for people to actually do their paperwork. Another feature we often provide in emergency departments is a decontamination shower room, which you can enter from the outside. In case you are in a chemical spill or something like that, get a shower before you're brought in. It's not required for a hospital of this size, but I think there's agreement that yes, we want that because of the nature of the district.
Yeah, I mean, I think, it kind of speaks to the collaborative opportunity piece where, tying in, I can tell you from experience, the one area that was a hot button topic where I was before was the ambulance bay. It was a covered bay, and it was the ambulance had to back in. There was clearance issues. There was exhaust issues when it was in there. There was a lot of modifications that had to happen after that to make that accessible, and that was certainly something where the volunteer group wasn't involved in. So I think those things are really important to have involvement. Yeah.
Well, just from a design standpoint, I can't recall who said it, but I think the preference is to have an emergency access that's flat and not on a slope. And currently, we have a ramp, a change in elevation going through that driveway.
Higher roof.
Yeah, if you notice in the one thing I didn't really like about the design on, the in-place design, aside, just the 3-story structure, but right now, you don't really notice the 2-story structure because you have access points on both sides of the building because it's on an incline, and then you basically have a street entrance on both sides. You don't really have to deal with that right now. but on the 3-story, you definitely will, and it's very noticeable. I mean, that was another one of the experiences going from a single-story building to a 4-story building, basically, was quite challenging for the community.
In that first option, Phil, where was the emergency entrance? Was it on 3rd Street?
It was at the top level.
By your house.
Thank you.
I'm not sure how it operates here, but if the EMTs come roaring into town at high speed with their lights and signs, full blast, that would certainly be a problem, but I would hope it would be more discreet than that.
It depends if we include them on the design, I suppose. All right, any other questions? Thank you so much, Dan. It was really important. I mean, obviously, price points, I think, a big focus of the next steps on where to go and what kind of funding opportunities as well. So,
You want to mention some of like the grandfather things that the hospital has, the size of rooms, all that kinds of stuff.
Oh yeah, I mean, once
those could go away be rescinded at any time.
Yeah, I mean, for anyone who hasn't received the tour, I definitely go through it. Mike, he can speak to it as well, but he knows all the details. But as soon as we break a wall for renovation, we're subject to the newer regulation. And then, which is always a challenge, we also, right now we're grandfathered in, like you're saying. And again, I mean, there's some risk because the load of the electrical. We just, they could change that grandfather to not being grandfathered in. So there are some risks out there. I question whether I wanted to advertise all of them, but but you're right. Interest in transparency. We do have. Right. Brian picked right up on that over in the pilot. Yep. There's some risk. Yep.
But anytime you do a modernization, you have to follow the new rules.
Right.
So it means room sizes change and electrical requirements change.
Yep. Mike, you want to add anything else? Regulators coming in tomorrow. All right. Anything else on the master planning and facility? No. Again, I want to thank Dan for coming up. He flew up here, and I don't even think we had this in the scope, but thank you.
Robust participation.
All right, great. If we want to hit up, I mean, it's good we covered some time. Do we? If there's nothing else to add on that piece, do we want to talk about the agenda items with the liaison and the collaborative opportunities? If we want to talk about those, I mean, we kind of touched upon those as well. My comment on the collaborative opportunities, I mean, I don't know how much detail we want to get into here, but I'm completely supportive of opportunities for collaboration. I think one of the things we could do is maybe just assist in setting some dates where we can meet with the department heads that are, that oversee some of those departments, along with some of the staff from the assembly or borough that oversee those departments, and sit them down together. We work closely with some things just to keep you updated on where we're working closely with this Parks and Rec. We have a therapies group and long-term care that we were able to get lifeguard training, and what is nice about that is that we can provide therapies and long-term care residents to go into the facility, into the Parks and Rec, without necessarily having to have the expense of a lifeguard if they have lifeguard training. So that's something that Chandra's been working on with us. That's really beneficial. What other areas that I'll think of? I'm trying to make some notes here. The health insurance was something that we worked together on. I think was a huge benefit for collaboration. So very open to collaboration. I think it makes a lot of sense to be able to work together. I'd love to do more with Parks and Rec and wellness. That ties in directly with health. Getting active, providing opportunities in Parks and Rec to be able to do that and support, the facility and being open and things like that. So. Assisted living, would love to have conversations about, how can help support that. It's something Steve and I have been, and Shelley have been trying to schedule a meeting, so it is on our radar. We'd love to sit down and talk with the department heads and try to figure out some collaborative solutions. So from the purpose of the meeting, I think one of the things that would be great, as a goal for next year is to actually sit down with each department head and try to come up with some opportunities to collaborate. Any comment on that? We talk about it more. All right, and then liaison, did you want to talk about that, or you want to keep that, or what's your thoughts on that?
Well, that's what was put on the topic. Some people wanted to talk about it here. Some of us were involved when it was originally set up, back way when. And the intent is to get better relationships between the two groups, really, is what it was intended for. But I've sat now for the last year in the meetings, your meetings, and I've not said a word, and then I come back, and there's really nothing to be said because you've really done a good job of taking care of it. I feel like kind of a box is sitting there and I haven't done anything. I'm really not sure it's really needed anymore. And that's where I was trying to get the assembly to agree with me. But then I said, no, I need to talk to you folks at the same time. And so that's where it came about. And so I really would like to do away with it, but it's up to the group what they want to do with it, because it really hasn't. I haven't done anything other than sit in the meetings, and I think I've reported back once, I think, in a year's time, so.
Would it help, instead of necessarily coming, at least getting the agendas and what's, get the meeting?
I get the agenda.
Right, but if something of importance or interest, then come to the meeting.
Yeah, and I read it, so yeah.
Right.
But it's whether or not I can do anything to help, and then what role do you want to perform? That's the other side of that coin, and that's my question.
Well, I personally think with the CEO, Mr. Hofstadter, coming to once a month almost and giving us an update to the assembly, it kind of is, in a way, he's the liaison, I feel. And we're getting probably a more detailed picture of what they're working on. That's just my feeling. I don't know if it's something we'd have to say do away with, but I guess it's up to if we have interest from the assembly members. I don't know what everybody else thinks.
Well, if he keeps doing what he's doing a good job at it, then if he's fine with it.
I agree. I think that the monthly reports were helpful, and I think it keeps us up to speed. I think that's fine.
If you don't mind talking about it.
Yeah.
I always, the only caution I had was if it wasn't me, if you were looking at it from a system standpoint, it does make sense to have a liaison. I do think, even though it doesn't seem like it, when we meet, I think it's helpful for me to know, and I end up meeting with a lot of you anyway, but.
And Phil and I do meet, maybe not monthly, but often really when there's an issue that comes up that we talk about.
Yeah.
And most of the assembly members that want to talk about hospital affairs will go to Phil, and they should anyhow,
It's in, I don't know if for the board,
Yeah, I mean, it might be good to have you stay as the liaison, but you may not necessarily come to the meetings all the time.
That would be helpful.
I think that's
There's an issue, we can contact you and you can
Give him a phone call.
Yeah.
We need you on this one.
And if you see something on one of the agendas, then you can contact Bill or Chad or say you want to come or talk.
Anybody can call,
Right.
if they want to talk, that's another part of that. Phil knows that, they will call, say, I'd really like to meet type of thing, and I think that's great.
Mm-hmm.
And I'm okay with leaving it that way.
Okay. Yeah. All right. Okay, moving on, just CAPS's priority and healthcare legislative, just a couple of things. I don't know what's going to happen at the legislative session this year, but it's something that, is on the concern. Just from your input, your information is, my strategy is really to just try to work with the state. The state's actually been really good, the people I'm working with, to try to come up with a strategy or a demonstration project with the state and keep ahead of it instead of being on the receiving side of a regulation change or a slash or a cut. And so I'm trying to be very active with the folks at the state, and I have to say they've been responsive. At every community cafe, practically, we've had the director of public health here, Heidi, and she's a strong advocate for the state. I talk with the medical director at the state, Dr. Zink, often, and I've even talked to the deputy commissioner. I'm on the medical care advisory committee for the state, and I will be attending a meeting next week, actually, where there'll be some of the folks that, make recommendations to the commissioner. So I'm trying to stay ahead of that. I know that there's only so much we can do with the cuts at hand, but I'm really trying to make sure that we're on the front end of that as opposed to be on the receiving end of that, and potentially being on the front end of some kind of innovative payer change. There's some things the state's interested in related to the way Medicaid pays out claims, and trying to be in on the front end of that is something I've been working hard towards. So I'll keep you posted on those. I don't have a real strong legislative update, then everyone's just like you all are, just keeping a vigilant eye on the state and trying to keep a pulse on it as well to find out what's going to happen next. And as far as CAPS's priority, we really appreciate that the new facility is, if the state ever does fund capital, that we would be on that. I was very pleased to hear in the forum, too, that there was strong support for that, and we'd love to have your continued support on that. So thank you. And thank you also for supporting the things that initially don't have a funding amount, and that was a letter to the governor for HPSA designation, which is a healthcare professional shortage area. And again, we didn't get that designation because the state has to ask the feds for that, and they have strong regulations related to that. But I can tell you, as a result of that letter, is one of the reasons I was able to talk with the state so openly and open some doors related to these other things at the legislative session. So thank you. I want to thank you for being able to provide that. So,
do you think, Phil, excuse me, do you think there's any way that the borough could do anything to help the state? Would they encourage the state to go to the feds?
I'm still working on that issue, actually. They've actually assigned a primary care officer on this exact thing because of that letter, and it's still ongoing. So, yeah. I'll let you know, though. Yeah.
Would our federal lobbyists that be an option to?
We've had that discussion before.
Okay.
Haven't we, Manager, the hospital board, et cetera, using our federal office?
Yeah, we'd have to talk through their contract and make sure that there's,
Well, a letter from y'all or something saying.
Correct.
That the borough's interest, getting that status.
In particular,
level.
information is sometimes hard to get to at a federal level, and we can easily ask our federal lobbyists, we want more information about this, and they can do that. Actually lobbying for something, we have to talk through that process. But, yeah.
At least have our our lobbyists know about our interests.
Yes.
So if they hear something, or they can whisper something in someone's ear, maybe.
Okay. Anything else? So for next steps, just to chip down the agenda item for D, next steps for us are obviously I'm hearing we will set some dates and timelines, and it'd be helpful to have some support for to getting the right department heads around the table for collaboration. I'm also hearing we'll have NAC provide a follow-up on the final report from master planning, and we'll be able to get that with you. And is there other next steps you'd like to see that I can jot down?
So I would like to make, not related to that, but a comment, is that I've sat through your meetings for the last year, and one of the things I'll say to our assembly was that Phil has put, as he said, tremendous emphasis on the financial side of that thing. And I sat through quite a number of meetings where they looked at changing the way of doing business. And one of the things that really shocked me was the amount of time it takes to do Medicare billing. And I learned a tremendous amount I never knew. I don't want to get into the specifics of it, but I have empathy with now trying to figure out how to do it when all the coding changes and they have to change everything going back a number of years. I think the last meeting I sat through, you were back, 3 or 4 years, I don't remember what it is, we had to change the coding on the stuff that was done that far back. It was ridiculous, but
It's extremely complicated, yeah.
With them now and trying to get them to work.
Yeah, thank you. I mean, it's extremely complicated. It's never as easy as it seems. This relates to bills. You have different payers. You have Medicaid, you have Medicare, you have Aetna, you have United Health, you have Primera. I mean, it just goes on, and it's very complicated. So, yeah, thank you, and thanks to the staff.
Getting the Medicaid is the worst one because they pay us and then we have to give them money back.
Medicare and Medicaid cost report. I do want to comment a little bit on the cost structure. So there is one difference, when we talk about new facility and where it differs a little bit from like a library and a post office and other buildings, is that we, as a healthcare facility and a designation, we're designated as a critical access hospital, and that is a designation by CMS, which is a Center for Medicare and Medicaid Services. And what that allows us to do is, as a requirement of that, it means that we have to have a 24/7 emergency room coverage. It means we have an inpatient unit that has to have a 96-hour period, which means that anybody that has to stay in there over 96 hours, we have to transfer that care out to a higher level care facility, a tertiary care facility, unless they have meet criteria like a swing bed. And so to speak to the billing complexities of that, daily, it's a struggle where you have to get approval for maybe staying a little bit longer in our acute care beds in that status, that skilled nursing status, and to provide rehabilitation through therapies. We also provide long-term care under that designation as well. In most places in the lower 48, for example, a long-term care facility and a hospital, a critical access hospital, are completely separate, and a primary care. They're not under the same roof. So we are very fortunate in Petersburg that it's all under one roof. We capitalize on things like shared staffing, and when we have a new facility and new master planning, we're saying we want these departments close together because we want that shared staffing that saves cost. So I don't know if people are aware of that. And then as a result of being a critical access designation, we actually can take our expense of doing business. And even though we don't really have a positive profit margin. I mean, it's like 0%, 1%, negative 2%. We're very fortunate. It's a tight margin. Even though we're growing, and even though we get these grant opportunities, it's still a really tight margin. When we provide a cost report to Medicare, for example, it's very complicated. We have to hire somebody out of Juneau, and we have consultants come in, and we have to send them this information, and that information has to be accurate, and it's extremely complicated to pull that information together. But one of the benefits of that, one of those areas, is the depreciation and the facility and the space size. That is a component of an expense. So it's not just, when you have a fully depreciated facility, you don't get a good return off that cost report. If you have a new facility, actually, the rate of return actually goes up. And now, I'm not saying it's one-to-one, but it's something that's different than a post office and a supermarket. And you can benefit from having a new facility because you put in the cost report to the federal, to CMS and to Medicaid, and you get a return off of how much expense that you spend. Now, you're not going to make a profit, but at least you can have assured that you can break even a little bit. And that's a regulatory change that occurred in the 90s, and because a lot of critical access hospitals were closing doors. So it's called cost-based reimbursement. So if you have a bigger square footage, if you have a higher expense to operate the facility, if it's a new facility that's new on a depreciation, it's not fully depreciated, you can calculate that amount into your return. And that is something that a lot of folks don't know. And that's one thing, that's why it's really important to, I hear these comments, let's just change it to a clinic. Well, you lose that benefit. You lose that designation. Once you lose that designation, you don't get that benefit at all. And it's just it's a slope of no return where you can't really obtain that service again. It's really hard to return that service. So I just want to mention that because it's something that comes up a lot when you're talking about new facility, types of services, and also the way that a critical access hospital obtains funding. And it's not just, you come in and, you pay for service and then it goes away. That expense can actually be put out in the cost report. So thanks for bringing that up, Bob, on the one side, because it reminded me to chime in on that. I wanted to make sure that the borough was aware of that designation. All right, anything else? I think we're on next steps. All right, and then I think, Member Lucci, you wanted to talk about the BMC Borough relationship piece.
I did, thank you.
Yep.
So from time to time, when we're talking to folks in the community, sometimes they ask, so why is the hospital and the borough related? According to the charter and the ordinances, the hospital board and the hospital is a total separate entity from the borough. Hospital board hires you, and we don't really have much oversight of the hospital other than once a year meeting. And I'm just trying to sort out, would it be beneficial for the two entities to be separate, completely separate, or what is the draw for having them together?
Yeah, go ahead.
All the board members of the hospital are publicly elected as part of the process. For one thing, all property is owned by the hospital.
Well, and we are, the borough and the hospital are not separate entities in the borough code. We are joined at the hip, however, the hospital is given as much autonomy as possible. And that's still subject to review by the assembly.
Right. Part of it, I think, was to take the load off the assembly. Because
we'll be happy to take some a subsidy if you want. Make it more of a attention. No, to answer your question, I don't have I don't know the borough hospital relationship is to a level of a detail to answer your question. I do know, I've read up on the history, I know this was reviewed in the past. I can tell you my feeling on it is that I think from a community standpoint, when you look at core structures in the community, healthcare and education really stand here, and do you call it, with the ambulance as well, fire and ambulance. Those are all in law enforcement, obviously. Those are really core entities. So from a community standpoint, I think it's really important. I can tell you from a grant standpoint, it's highly beneficial. From a standpoint to the state, talking as a community hospital, it's very powerful because the goal is to really serve the community, and I feel like there's a lot of value in that. From a financial standpoint, I don't see a way to get around PERS liability. PERS liability, goes back to the borough. My understanding, right? If we, that's a $12 million hook right there. And I think that's enough right there, right? But so those are my comments on that. I would prefer, I think we stand stronger together. Personally, I feel like that is collaborative efforts. I think we can potentially, but those are all sort of personal feelings, I suppose, coupled with some facts, I think.
Well, I think the other aspect to it, and you've really done a great job at it, is it demands more transparency from your hospital than you would have if we were a separate entity. We certainly would want to serve our customers, but we wouldn't have the same obligation to be as transparent to borough government. And I think that what I hear from the people of Petersburg is they like that transparency. They want to know what's going on. They don't want to know what we're thinking. They want to have input on the services that we offer.
Yeah, I agree with that. Yeah. Having community buy-in on moving and operationalizing things, I think, is a value added for sure. Yeah. It challenges us too. Yeah.
Sure. Thank you.
Yep. Anything else? Are we really going to get out of here 40 minutes early?
There's just one other thing that I wanted to add. When we brought in AARP, Ken, the speaker, talked a bit about designing homes and also communities to work with people as they age. And so I asked for more information on that. Ken actually sent me some bulletins, and there are multiple copies that I will share with the Assembly. I haven't had a chance to look at them yet, so I haven't passed them along. But there may be some opportunities there for the hospital, for individuals, and also for the borough to add some of those things in as we do planning in the long term. So that will be forthcoming.
And that's sort of a new area too, is home health care and trying to work with people so they can stay in their homes.
Yeah.
And to provide services in the home.
Yeah, it's going to be a growing area for sure in healthcare. That's another area I was really interested in working with the state on as a demonstration. Yeah.
It's big across the country.
Mm-hmm. Yeah. Yep. It's a focus area in every part of the country. All right, great.
Looking forward to January. Thank you.
Thank you very much. Any other comments at all, or are we good to go? Thank you. Yeah. Thanks everyone for attending.